All right, we're recording. So item 1, I'm going to point out some things here because I know some of you are like, I can't wait to go back to endocrine, the lecture. Item 1, but this is the real thing, which I like. And when we hit the little dip, you won't believe we actually, for 2 years, we were like 88% pass rate on the boards. And we're like, we had a summit, emergency summit. And I said, I got an idea. We need to have a lot more question review. I need to come up with some strategy tips. And we need to do a bigger Lezama pictures with stuff. And so we changed that. So we kept a lot of the core the same, but then added a lot of question review. And that's what you'll see during the summer. And what you've seen a little bit today of is that presence of examining the questions and saying it can't be EVV because it's 1% atypical lymphocytes. Nightmares is what's being described. I'm going with the beta blocker, etc. So this is a 36-year-old man who is playing softball, and while he's running to first base, he passes out. And he's experienced syncope while exercising, even though the fact he's on a beta blocker, which actually making things worse, that he's on a beta blocker, which he was started for hypertension. He's fairly sedentary until recently when he was starting to play some softball. On the exam, he's got a normal intensity first heart sound, a paradoxically split second heart sound, which can be normal. Doesn't have to be abnormal, but if you find an abnormality on EKG on a paradoxical split second heart sound, you have an underlying left bundle branch block. And one of the things I did a few years ago, which you'll see in the first summer session, I'm going to give you the top 50 short, best 2 to 3 liner questions. And because you have to get used to those short line questions, like the one about, I call them the bullshit questions, and also the straight up, do you know it or you don't know it questions. So that's how we're going to start the first summer session, is with the top 50 of those questions. And then we'll get into the longer stems. So I'm going to get you ready to answer the 25 to 30% 1 to 2, 3 liners on the boards, as well as the 75% of the paragraph questions like this. There's a little mid-systolic murmur heard. Again, it decreases with standing and Valsalva, which is what it's supposed to do physiologically. When you have a physiological murmur, it's supposed to decrease with standing. It's supposed to decrease with Valsalva. That's a good thing. So anyway, and sometimes if it's exaggerated, then you would be worried about mitral regurgitation. But if it's not that exaggerated, it just could be normal physiological murmur. So here's the EKG. What you notice on the EKG is there's a very short PR interval, and you see these little indentations where, I think you can see this, where these QRS complexes are going up, and those are delta waves. So this person has Wolff Parkinson White, and when they were placed on a beta blocker, they made things worse because you go down the bypass track. So the question says, which of the following is the most likely ultimate therapy for this patient? The ultimate therapy for this patient is EP ablation, right? The short-term therapy for this patient is get them off the beta blocker. That's the short term. You don't want anything that blocks the AV node, but it said the ultimate therapy. So watch out for key words, because if it said the next immediate step of treatment, it would be to stop the beta blocker and switch to another antihypertensive agent. But since it said ultimate, the answer becomes EP ablation. So Harsh is like, I can't take this. So yeah, you can. You're good. So he's just trying to get comfy. So it's hard playing center field. I never knew playing center field. Should I go a little more this way, a little more this way? Always put me in left field, shortstop, or third base. I always had it. I hated center field. All right, item 2. 92-year-old nursing home resident with mild Alzheimer's has back, chest, hip pain, and generalized weakness. She has resided in a nursing home for several years. Apart from dementia, she's been doing okay, but her strength has decreased over the last few months. Her calcium is 8, low. Her phosphorus is 2.3, low. Albumin 3.7, which is fine. And her OCT is slightly elevated, with normal being 120 at 138. She has multiple old rib fractures and osteopenia, but they find something cool. On her x-rays, there's thinning of the cortices and loss of trabeculae with radiolucent bands noted near the femoral neck. And what that's called, it's called pseudofracture sign, also known as loser's lines. L-O-O-S-E-R. So loser's lines, like big L, loser. And so what disease fits best giving the nursing home resident state? Vitamin D deficiency, choice C. This is osteomalacia that's being described to you. Choice C. I know a lot of you were like, Paget sounds good. They're old and their alk phos is up. They're Pagets. So not everybody who's old and has a high alk phos has Paget's disease. So here was the answer was osteomalacia, vitamin D deficiency. So I like this question. The first two, I love those. So this one, the answer C, vitamin deficiency. Number 5 is straightforward. It's a Wegener's granulomatosis. Very straightforward. 5 is C. 7, 43-year-old woman has itching that keeps her up at night. She has a big liver. Her ALT is slightly elevated, but her alk phos is 3 times normal. Which of the following would be ordered next? C, right. Antimitochondrial antibody. Don't overthink it. Primary biliary cirrhosis and antimitochondrial antibodies what you would order. What is the next step in management? Ursodeoxycholic acid is correct. Phil's like, wow, I'm on a roll. So good job, Phil. Crystal's like, settle down, Phil. That'll be her next year, all year. Phil, settle down. So, all right. Number 9 is a long question going over plantar fasciitis. Long question. Let's just say you'll read this when you take the test and say, this guy has plantar fasciitis. Now it's, do you know what do you do next for plantar fasciitis? And what did I teach you in the tips? Non-pharmacological beats pharmacological. So the first step in management is C, use of heel cups and Achilles tendon stretching exercises. How cute. So that's the answer. Gree's not into that. So heel cups, no way, Jose. So it's like, this is crazy. Acute, chronic, acute. That's what I keep telling myself. So, all right. When would you do podiatric referral for neurectomy? When would you do that? That would be a Morton's neuroma. No, not after. You never do that in plantar fasciitis. Phil. All right. I think Phil started drinking already. So, all right. Anyway, no, this is a wrong diagnosis. So it would be for a Morton's neuroma, which, remember, a Morton's neuroma, the pain is usually between the second and third toes, and it hurts the most when you're walking. So all the time. It wouldn't be worse first thing you wake up in the morning like it is for plantar fasciitis, and then it gets better as you walk more. That's the story of plantar fasciitis. The story of Morton's neuroma is it hurts all the damn time that you step, and it hurts just the same. And for that, there is no heel cups or Achilles tendon. It's straight to surgery for Morton's neuroma. Morton, Morton apostrophe S, neuroma. If you're like, don't we just send these to the podiatrist? No, you have to have some podiatry knowledge on the boards. 13, you have to have a little bit of a soul too. Patient presents to your office with severe earache. You prescribe cephalosporin. Actually, this might change now, but anyway, let's say just remember, for your boards, first and second generation cephalosporins and penicillin still not compatible. For your boards. Real life, the new data showing probably very safe. But this person goes in an anaphylaxis from a cephalosporin after they had a known history of anaphylaxis for penicillin. Look, even in today, you would have a conversation with the patient and you would say something like, Carolyn, I know you've had severe anaphylaxis to penicillin, but the data shows that first and second generation cephalosporins are safe. What do you think? And Carolyn might be like, forget about it. You ain't putting me on that. All right. And you document, doesn't want it, or you document they want it. In this case, it's not done. And then you're horrified to discover that there's a severe allergy to penicillin that you blew right past. What should you do? I love the, apologize and offer to compensate them financially. So we all know that money in the pocket now, you make a strong offer. Yeah, that's what I did with Joanne. I made a strong offer. She said yes. I could have offered her $40,000 more. So anyway, I'm joking. So Cameron's like, how much are you making? You don't want to ask Joanne how much she's making. So all in fun. I'm having fun. So anyway, and then I like attribute the rash and the bronchospasm to the infection. It's just really bad. I love that. So, and they say, I like the D is explain to the patient that now he's allergic to cephalosporin and the penicillin. We now have expanded. I like, this is the Alec Baldwin choice. I am God from Malice. So no explanations are necessary. Me, doctor, you, patient. All right, so the answer is A, apologize and explain what happened. That's what you should do. So, all right, Dusip is a Malice fan. So, actually, first movie I went to as a medical student, I kid you not, was Malice. It was summer of 1993. What a horrible example for a first-year medical student. So anyway, then I went to watch The Fugitive the next day and saw a better movie. So that was how long ago this was. If you're like, wasn't that 1975? No, it was 1993. All right? I'm not that old. 17, 38-year-old woman presents with 4 weeks of progressive weakness and difficulty in climbing stairs, getting up from a chair, and combing her hair. She's developed a violaceous erythema over her upper eyelids with periorbital edema. She has macules over her neck, upper back, and shoulders. Her CPK is 8 times normal. So we have no doubt she has dermatomyositis. The question is not asking us that. Of course not. So we have to pick which of the following is true. So A, dysphagia is an uncommon symptom. Well, that's incorrect. Dysphagia is common because they get esophageal smooth muscle weakness. B, weakness is usually acute. That's not correct. You don't just like plop over and go, oh my God, this guy has dermatomyositis. It's several months of history. C, in addition to the eyelid involvement, a malar rash is typical. No, wrong disease, that's lupus. D, the more extensive the skin rash, the worse the disease activity. Wrong, it's the opposite. The more extensive the skin disease, actually the better the outcome, ironically. And then E has to be correct. So even if E was in Greek and only Chris could read it, you would say E is the answer. Because A, B, C, and D are wrong. And this gets to a concept of board review, which a board preparation, which I wanted to get to, is sometimes you get the right answer just from knowing the other ones are wrong. Even though you can say, I'm not sure about E, but clearly A, B, C, D, as we went through, are not correct. So the answer here is E. Deep tendon reflexes are unchanged, and they are unchanged because the neurological system is not affected in dermatomyositis, as opposed to inclusion body myositis, which can affect the neuropathic system, inclusion body myositis can be neuropathic and myopathic at the same time. But that's the only myositis that has that ability, is inclusion body myositis. Dermatomyositis and polymyositis are pure muscular diseases, pure myopathic changes. Everybody cool with that? Cool. These I picked on purpose. 21, another liver one, which I picked on purpose as some people struggle with liver. 22-year-old, and despite the fact I send you to GI clinic way too much in your own words, y'all still struggle with liver questions and derm questions, but now you like the derm clinic, and so I just slipped a benzo in Dr. Laffer's drinks. So you'll notice a different Dr. Laffer. So shh, just don't tell him. So I'm joking. I kid because I love. So although I'm happy about the dermatology, I wasn't kidding about that. So I wasn't loving the old regime in derm. So I love the new kids on the block. I'm trying to get them to do a video. They refuse. I'm trying to get them to, like lip sync a video. And Dr. Shaw, maybe you can help me because the answer has been no. So I'm trying. Maybe Danny can trick him into it. We'll see what we can do. All right. Anyway, so this 22-year-old woman has had fatigue for 8 months and dark urine, which she first noticed 6 weeks ago. Positive physical signs include scleroicterus, multiple spider and telangiectasias, and a big liver. Her ALT is 780, her AST 680, her bilirubin is up, her alk phos is barely up, her albumin is down, and her serum globulin is elevated, as we would think in these autoimmune diseases you can see commonly. So this one kind of looks like the other question. Remember, I gave you an autoimmune hepatitis in the last set of questions where you had to choose prednisone. Now this is autoimmune hepatitis, but you have to tell me what's the best way to get to her diagnosis. And you're flocking to the antibodies, which I hate to tell you aren't there. So now what do you choose? Biopsy, very good. The answer is C, percutaneous liver biopsy, which is the way to definitively diagnose PBC and autoimmune hepatitis. Very good. That is the answer, choice C. I'm impressed. All right, 31. Sometimes the choices aren't ideal. 50-year-old farmer with CLL who participates in the slaughter of livestock comes in with a meningitis. So his lymphocyte count is at 30,000, which is stable for him. They tap him. He has a high CSF protein. Or sorry, he doesn't have. Yeah, high CSF protein, my bad. His glucose is okay in the CSF, but his protein is high. But he has a lot of cells. So he does not have cytoalbuminologic dissociation. He has lots of cells and high protein because of lots of cells. And he's got 4 red cells, so it was a fairly good tap. Gram stain shows no organisms. What's the appropriate therapy for this patient? So my perfect answer would be ceftriaxone, vancomycin, and ampicillin. My perfect answer is not up there. And sometimes your perfect answer won't be up there either, and you have to adjust. And so the first thing you do to adjust is you do question-answer reconciliation. You can't ignore the fact this person has CLL and they're dealing with livestock. 2 risk factors clearly for listeria. The answer has to have ampicillin. Has to. And so the only one that has ampicillin is D, and that is the correct answer. Ceftriaxone and ampicillin. I would rather empirically start with ceftriaxone, vancomycin, and ampicillin, and hopefully the culture will show listeria, which it probably will, with 1,200 cells, even though the gram stain was negative. The culture will probably give us the listeria answer. So that's how sometimes you have to adjust to something that's not the best choices that you would have. All right, let's do a couple more, and then I'll turn it over to Kelly. So 11 is a long question, but basically, if you are hyperthyroid with PTU, and now you're pregnant, you should go back on PTU. Pretty simple concept, and that was the answer here, which is D. You can't, for somebody who has underlying hyperthyroid issues, you can't just give them a beta blocker or control symptoms because you got to worry about the baby. So, all right, that's why you can't just say, I'll just treat their symptoms. You have to go above and beyond and treat the underlying disease because there's a baby involved. Number 12, a 28-year-old man came to you for a testicular mass 6 months ago and was found to have a non-seminomatous germ cell tumor, metastatic to the lung. He underwent chemotherapy with cisplatin and bleomycin. Usually they give him a etoposide, so let's say that too. Now, however, during the last cycles of therapy, he's having painful blanching of his fingers upon exposure to cold, stiffness in his hands, and shortness of breath, and has moderate pulmonary fibrosis. What's the likely reason for this? Bleomycin, X, or E. So when it looks good, go with your gut feeling it looks good. 23, a 68-year-old woman comes to the hospital with recurrent cervical cancer. She's malnourished. She's placed on TPN with lipids. 3 days later, she's found to have a fungus amongst us. So which is the fungus amongst us likely present? So Dr. Rice is present, right? Malassezia furfur, right? So Kelly, I said Dr. Rice is like Malassezia furfur. Usually, he's a nice guy. He's a hyperpigmented or hypopigmented rash. You know, nothing too bad. But when he gets pissed, he gets fungemic. So at which Joanne and Cameron are nervous, as they are Phil and Crystal. So they can handle him. These 4 will handle Rice very well. So C is the answer, Malassezia furfur. Now, what is Malassezia furfur beat for as an answer that's not up there? Candida. So when you see this question, don't go, oh, Malassezia furfur, this is great. And then if they put Candida on there, Candida beats Malassezia. So that's where you got to be good, is to watch out for those subtleties and why this board test is challenging. But why, again, we have those 3 sessions in the summer. Shameless plug, as if you had to pay for those sessions, they're free. But you got to admit, if you had to pay for them, I've done a good job of really bringing them up. So D'Souza's like, I'm in. So, all right, anyway. All right, just bring me a Mountain Dew. There we go. That's payment enough. 25, 38-year-old farmer has acute onset of severe progressive dyspnea, cough and weakness 1 hour after they go into a silo filled with fresh corn silage. Wow. Yeah, if you don't get this right, Callie, let's just stop tomorrow, send it back to their duties. All right, D. I said it like 3 times already. Nitrogen dioxide pneumonitis, which is silo filler's lung. So, but let me give you one to watch out for and show you. I have this here for a purpose so that you learn how tricky they can be. So, I have another farmer. So let me show you. He is coming up in a second. Farmer Bob, where are you? Farmer Bob, where are you? I know you're here somewhere. Where is the damn farmer? I thought it was here. This is a sneak preview. Here it is. See, the Farmer Bob is here. Number 88 is a 35-year-old dairy farmer who's never smoked and has chronic cough productive of sputum. On physical exam, mild wheezing was heard on expiration. Spirometry shows mild airway obstruction. Findings on x-ray are normal. Lab evaluation shows mild eosinophilia of the peripheral blood, clusters of eos, and serum precipitants to thermoactinomyces vulgaris. Which of the following is the most likely diagnosis? Asthma. All right? And a lot of you were like, oh, farmer's lung. I'm thinking, you hook, line, and sinker. They all threw the net and they caught like 21 residents. So, asthma. So guess what? Farmers can have asthma too. So, shocking that does not protect you from asthma to be a farmer. So, all right, it's like working in a cancer center, you don't get cancer. No, don't work that way, unfortunately. All right, so, and the key here is if you're going to have farmer's lung, you're going to have peripheral infiltrates and restrictive lung disease, not obstructive lung disease. But I'm telling you, if I had asked you to circle the answer, most of you would have gone farmer's lung here. Or maybe chronic bronchitis, where the answer is asthma. Asthma. So what was described to you as asthma, and in this case, the farmer this is the one situation where they could try to get you. Very few times do they, but this is so, I can tell you, this is so classic that this is asthma that they can do that. That, they can even say the guy has PCT and it still has asthma. It's not anything to do with his Hep C. So, all right, I'm going to do one more, Kelly, and then I'm going to turn it over to you. No, they're tired. I mean, I'm tired. I'm calling for an Uber driver. So I'm gonna leave my car here. So I'll pick it up tomorrow. There's one I was really excited about, and when I get excited, I'm like, damn it! Oh, this one's. See how sometimes it's a picture or a question. This is somebody who has a brownish macular papular spot or multiple spots, and rubbing one of them, not all of them. All right, one of them produces an immediate flare. This is Michael Agastine's urticaria pigmentosa, skin-limited mastocytosis. The answer is you biopsy, you'll find mast cells. So that's a way that they can either show you the picture or give you the description without the picture. All right, and then this is the one I want to do. So sometimes 63, same concept. Sometimes we see a drug and we know it's not the best during a state like pregnancy and we're tempted to take somebody off the drug. So 63, 30-year-old woman will well-control epilepsy while taking phenobarbital, wants to get pregnant in her next 6 months. Her last generalized seizure was 3 weeks ago and ran out of phenobarbital 2 weeks earlier and had a seizure. Other than a single seizure 3 weeks ago, she's been doing well and her EEG is normal. She says, I'm getting pregnant now, and that's what she stated, and she's going for it. So in addition to giving folic acid now, which we rather her wait 6 months to give her folic acid, but still we'll start folic acid now. Which of the following should we do? One is withdraw patient from medication during her pregnancy. Wrong. She'll get a seizure. Double her phenobarbital dose. This isn't Synthroid. No. Change her medication to phenytoin. Wrong change. So D, maintain current monotherapy at present dose. And the other one is get an EEG now, repeat it every 8 weeks. There's no reason to even do that because their EEG is normal. Even if it was abnormal, the next time you repeat it would be a year to 2 years. So the answer is D, maintain current monotherapy at present dose. If she was willing to change, then you probably would want to go, depending on what her seizure is, you'd want to go maybe to something along the lines of carbamazepine, which is tolerated better during pregnancy, depending on what her seizure type was. We want to avoid valproic acid as well during pregnancy But sometimes you just have to go with what the patient is dictating and the situation the patient's getting at. And when they stopped the phenobarbital, he or she was having a seizure. So imagine she says she's going to get pregnant and she's going to move forward. The last thing you want is her getting pregnant and having a seizure within a few weeks of that. So anyway, I will stop there. So